Over to you, Jen.
Okay, thanks, Millicent. So, hi everyone, both here and online. So thanks again for joining us. We are so sorry that we are starting late, 2:30 already, and we are supposed to start at 2. But thank you so much for your patience. Yeah. So right away, I'm going to invite Diana, who will take us through a briefing of what we did in the first workshop. This is the second workshop that we are having. So over to you, Diana.
I'm going to request Diana to sit where you are seated, Jen, please. Thank you. Thank you. Just sit where Jen
Thanks.
was seated.
Hi. So I think we can start with a debrief of last week. So last week we got to do the we met at Microsoft's ADH ADC ADC at Dunhill Towers, and it was a really more of a session to kind of just do the introduction of the challenge, the datathon, how the data set looks like, and then information. So with the data set, if you still do not have access to the data set, please make sure you do reach out to me so that I kind of guide you how to get access to the data set. Similarly to teams, if you do not belong to any team and wish to, you can also still submit the challenge alone. Please also do reach out to me. So that's what kind of some of the things that we did last week, and also an amazing talk from Lydia. So Lydia is the leads of the garage team at Microsoft, which will be going back to next week. You get to meet Lydia again next week and get to hear more from her. So what Lydia just talked about was kind of more of a motivational talk in terms of telling us what to do in terms of a competition, what it takes to be in a team, what it takes to be innovative, and kind of the guidelines of innovation. Then we did end the day with a networking session where we also still had the teams being formed and taking kind of some of the notes from the teams and the formation. So I think we can start with our first speaker. So I don't know if Kigo, you will introduce them with their bio. So we can just jump right into the workshop aspect of it.
So, hi everyone. My name is Kigo, and pleasure today to have our guests. Finally, so yeah, glad to have our guests today, and we thank you for honoring our invitation. The reason as to why we have experts is for you to connect the problem at hand with every industry application. Because if you just have the data, you may not join the dots. So we usually have experts who talk to us about the data and the problem we have at hand. This is about equity and healthcare. So we start with Dr. Wambui. Is an alumna of this institution. So people who are here in UN, a better place to show how back the Dr. Wambui holds two bachelors. You know, doctors have the privilege of pursuing two bachelors at the same time. So she has a bachelor of medicine, another one in surgery, also master's in public health. So she's an expert in the industry, and we are all here really to hear from her and learn so much about what the data has for us. So very interesting.
All right. So thank you, Samuel, for that warm introduction, and thank you for having me. So I'm very glad to be amongst you. I love what you're doing in terms of data and using leveraging on data. And I'd like to say that even before I begin my presentation, whatever you're doing is a very important thing. Right now, in the low and middle income countries, there have been a challenge in data use. low and middle income countries have been accused of just using blanket things, adopting things from the West, introducing them to our concept and trying to adapt. And what we find is that most of these solutions tend to work. So today I'm going to talk about a topic I'm very passionate about, which is health equity. And all right, so I think we can get right onto it, right? So basically, this is how my outline of the presentation will be. It will not be a very long presentation. I want you people to get a hang of what is health equity and how it comes and how data can come about. So we'll start with an understanding of the healthcare condition in Kenya. Then we'll do a bit of some definitions. We'll talk about healthcare access and we'll look at what the role of policy in health equity is. We look at some of the opportunities that we can leverage on in terms of health policy in achieving equity. We look at some of the collaborative innovation that can come in terms of AI and say data. And I'll give you some of the references in case someone wants to read more of any of the topics. So basically, let's jump right into the healthcare system in Kenya. So we got a new constitution in 2013, and in 2010 actually. So in 2010, initially health was a function of the national government. So whereby all the functions in health were for the national government. But what happened is that when we got the devolved system of government, then there was a transfer of some of the functions in the healthcare system towards the county government. So initially, the national government, when health was devolved, two functions were left to the national government. That is policy and the regulatory functions. Then to the county government, we transferred all aspects to do with service delivery. So that is planning, management, and budget. So what you realize is that you see, right now what's happening, policies are made at one level, then the implementation is another level. It's at another level, yeah? So national makes the policies, counties implement. So that usually presents a gap in terms of when it's not the same person who is making the policy, when it's not the same person who is making the policies and implementing, there is always a gap. So what you find is that the implementation becomes a challenge, and that is what we'll be looking at throughout this presentation, how based on this, equity is not being achieved. So we look at what is health equity. You know, we keep talking about health equity. We might not know what health equity actually means. So to understand health equity, let's look at what the opposite is. So what are health inequities? So basically, health inequities are defined as unfair, avoidable, and remediable differences in health status between countries and between different groups of people within the same countries. So the keywords here are unfair, avoidable, and remediable. That means these are all things that you can reverse. These are not things that are cast in stone. It's something that is reversible. And for you to say you've achieved health equity, it means that there is absence of the health inequities, right? And we say that health equity will be achieved when everyone can attain their full potential for health and well-being, so that we don't have discrepancies. We've said the unfair, avoidable, and remediable differences in health status can either be within one country, between different groups, or amongst different countries, say in the developed nations, in the low and middle income, or the developed nations. So when there is that discrepancy, then that is what we term as health inequities. Yeah. So there's another term I want to define. So sometimes they are used interchangeably, but what you'll realize is that they are actually very different. So there is one on equality and equity. So when you look at this pictorial representation, what you see is there are two groups of people, right? So in the first group, where the equality is, everyone has gotten one bar of step, right? But can you see the outcome? Can you see how the outcome is? Yeah. So the tallest person got one bar, and so did the shortest person, right? So the tallest person now has even a better view, while the short person still is not able to view whatever is being displayed or enjoy the game. Yeah. So that is what equality is. It's defined as each individual or group of people is given the same resources or same opportunities. Yeah. So most people will say, oh yeah, we already gave you people what you needed, yeah? But you see, what you're looking at is the outcome, right? So then what equity is, yeah, is that equity does recognize that each individual has different circumstances and allocates the exact resources and opportunities needed to reach an equal outcome, yeah? So you see in the second pictorial presentation, one person, the shortest person, got 2 bars and were able to enjoy the game. The person who was already tall enough didn't require to get a bar, and they can still. So you see the outcome at the end of the day, we've achieved what we wanted to achieve, right? And this is through a consideration of each individual needs. There's someone who would have needed 2 bars, there's someone who actually didn't even need a bar. So those are the 2 terms. If you ever get confused in terms of defining or it becomes complicated, just remember this pictorial representation. It will always remind you the difference between equity and equality. And we know what we are saying in health, we want to achieve health equity as opposed to health equality. Yeah? So then we'll also look at a concept we call the social determinants of health. So basically, when I saw that, I got a glimpse of the data set that you're using, I can see what they're terming as patient characteristics, right? So patient characteristics, they've indicated this to level of income, level of addiction. I think there was something about race, I think an environmental exposure. All those things actually are termed as the social determinants of health, yeah? So how we define them is that we define them as non-medical functions that influence health outcomes. And they are conditions in which people live, work, play, and age. So as we go along this presentation, we realize these are very, very, very pivotal issues in terms of achievement of health equity. So social determinants of health include things like level of income, social status, employment, level of education, someone's race, ethnicity, residence, their physical environment, social supports, and access to healthcare. So you see, all these factors are non-medical, but they do usually have a direct influence on the health outcomes of an individual. And that's why it was also very important for you with that data set to get that the patient characteristics, because the patient characteristics also influence the diagnosis and the treatment of the, let's say, breast cancer or whatever we're looking at in this instance. So here I've given some statistics that, like for instance, in Kenya, 6% of women have no education compared to 3% of men. And this is some data that came in with the Kenya National Bureau of Statistics in 2023. And what you realize is, you see, this low level of education usually has a direct impact in terms of the health outcomes of women. So what you realize, women tend to have a worse kind of health outcome as compared to men, just based on this one parameter of a lower level of education. So we usually say that for us to achieve health equity, largely we have to involve action through the social determinants of health, as opposed to closing our minds in the issues to do social determinants of health. Once we place them at the center, even for policy formulation, then we are going to be able to tackle the root causes of health inequities. So this map, this is a map I got. This is some statistics I got from their 2014 statistics on maternal mortality ratio. So in 2014, we still had the provinces. We didn't have a lot of the counties. So basically, why I brought up these statistics is the WHO usually uses some metrics to actually assess the health system in a country. So for us, for the WHO to actually know how the health system in a country is doing, it has given some parameters. So one of the parameters, it's usually known as the maternal mortality rate. So maternal mortality rate is usually defined as the number of female deaths per 100,000 live births. Yeah, for women, when women die during pregnancy, childbirth, or within 42 days after termination of a pregnancy. Yeah. So any factor, if a woman dies within this period, when they got pregnant, during childbirth, or with someone, unfortunately, in the unfortunate circumstance, they lose their pregnancy before maybe term, if they die within 42 days from this, then that's usually known as a maternal mortality. And maternal mortality is it helps to assess things to do with access, the access of care in a country, the quality of the care in the country, and also the coverage, how well the coverage is in a country. So basically what I'm trying to demonstrate here is, when you look at, it might not be very clear, but I can read for you. So here is a pictorial representation of the different counties. So there's the Northeastern, there's Eastern, there's Rift Valley, Western, Nyanza, Nairobi, and Central. So WHO usually gives a target. So they say that for you to say that your health system is actually working, say the quality is good, the access is good, the coverage is good. It's a country that has attained a maternal mortality rate of 147 deaths per 100,000 live births, 140 in a specified period of time. So when we look at our statistics here, so these just statistics from 2014 I picked. Look at Northeastern one. So for instance, let's start with Northeastern. So Northeastern, the maternal mortality rate then per 100,000 live births was 2,000. So we were losing 2,041 women per 100,000 live births. Yeah. Then look at Rift Valley. Rift Valley is at 377. We go to maybe Nyanza. Nyanza is 545. Nairobi is at 212. So you know what usually happens? The WHO doesn't look at clusters. It will look at Kenya as a country. So all these maternal mortalities, then when they are done when they are given now as an average, that is what they give us. Yeah. So in this year, in 2014, you can see the maternal mortality rate in Kenya was 495. Yeah. And you remember, I've told you the per target is 147, right? So this is almost four times of what the WHO recommends. But look at how it is, yeah? If Northeastern, just imagine if Northeastern was much better than this, say they were even at 500, then the rest of the counties even or the provinces were stationary. You see, our average would have been much less, yeah? So would have had a much better maternal mortality rate, yeah? So what I'm saying is inequities, you have to pay attention to everywhere. Like you cannot use one place in isolation. If we're using, let's say, Nairobi, and if Nairobi was a representation of the whole country, we would say that we are on the path towards achievement of the actual goal, right? Because we are at 212. Yeah? But look at a place that has 2,000. So you see, that 2,000, because of the inequities, that pulls us back. Yeah. So you cannot leave anyone behind, because if you leave anyone behind, then you know that you're not achieving exactly the goal that you're supposed to achieve, right? But so I just wanted to get a pictorial representation of just to see inequities in a country, within the same country. These are people who are in the same country. So you can see it's very evident that in Northeastern, there is something that's happening that's not happening in Nairobi, that's not happening in Central, right? So here I just did a graphical representation of Kenyan cancer statistics. And this one I just wanted for you to have an idea of how important breast cancer is, which is the kind of data you're working on right now. So these are statistics from 2020. And from the first graph, you can see it's representing the top 10 cancers by incidence in Kenya in 2020. And these statistics have actually remained the same, because till now, I know breast cancer is top. It's the most prevalent, it's the most common cancer in Kenya, right? Breast cancer. When you look at the second graph now shows the cancer mortalities in Kenya. So despite breast cancer being number one in terms of the incidences, it usually comes second in terms of mortality. But you see, the difference is not really big. The cancer of the cervix is number one in terms of mortality. But right now, as you can see, it's almost, the statistics have remained the same. Still, breast cancer is number two, even today, but there isn't much difference, yeah? See, when you look at, like, let's say, in the breast cancer, the incidence of breast cancer in 2020, you can see it's almost towards the 7,000 mark, right? So it's, let's say, 6,900 or 6,800, yeah? And when we look at that, then we go to the deaths, yeah? It's slightly above 3,000, yeah? So that means almost half of everyone who's diagnosed with breast cancer, they die, you see? So you see how important whatever you're working on is, yeah? And when you look at they've done some predictions in terms of the predicted trends in the incidence of new cancer cases from 2020 to 2040, yeah? They've also done the maternity. And what you can see is that everything is going up, yeah? It really is, and it's almost doubling. So they're even projecting from 2020, between 2020 to 2040, it's almost going to be more than double the incidences of cancers, yeah? So you see, it's actually something that is very pertinent. It's something that you should should actually be taken very seriously. And whatever you're doing with the data, if we always use data to base our clinical decisions, yeah, we tend to get better outcomes as opposed to just adopting whatever, let's say the Cancer Society in the US or in the UK, they decide this is what they are working, whatever works for their population, then we adopt it. So what we find is that we tend to use up a lot of money to implement solutions that don't even work and they don't have a good outcome for, because we're not using data, we're not using our Kenyan context data, we are borrowing data from wherever else, and it might not apply to us. So here I'm going to just tell you about healthcare access in Kenya. So basically, in Kenya, the current doctor to patient ratio is 1:17,000. So one doctor for 17,000 people, yeah? And the WHO actually recommends us to have one doctor for 1,000 patients. So you see, it's really very far off. They're very far from achieving whatever the WHO recommends. Eh? And then what you'll see, I don't know whether you guys saw something that came on the news recently, that some statistics that were saying that there are 4,000 unemployed doctors, right? You saw that, yeah? Yes, so currently in Kenya, it's even about 4,000, I'd say, yeah? It's more than 4,000. So what you'd expect is if you have 4,000 unemployed doctors, then it should mean that we are doing in terms of the doctor-patient ratio, in a way that we don't even need more doctors. Like we already have enough people who are working, yeah? That's what you'd expect, right? But remember, when I told you that health was devolved, right? So I told you service delivery went to the counties. So what counties do is, they're the ones who prioritize, they have the budgets. So they'll say, oh, for me, maybe a governor will say, for me, health is not a priority for me. So let me direct this fund to wherever else, right? So in that way, you see, they're not prioritizing health. So they're not employing people, they're not equipping the hospitals. And you find that it will be very hard for us to achieve equity with the devolved system of government. And that is something that we have to be very much aware of, because it's 47 people, it's 47 counties, yeah? Each person makes decisions for themselves. So there's a governor who will say, oh, I'm prioritizing health as one of my main agenda in this county. So they will make sure they equip the hospitals, and I'm sure you people know about it. There are some counties that really don't struggle with health, right? There are counties where they have doctors, the hospitals are well equipped, but then there are counties that are on the spectrum, like it's really bad, like the hospitals don't have equipment, there are no human resource. So you see, these people who don't have enough human resource, what are their outcomes going to be? And remember, all these outcomes are going to ultimately influence, because you see, we don't usually look at clusters just as a straight, it's the whole country, right? So if you don't have equity in the whole country, we have maybe I'm sure there are some counties that the ratio is better than this, yeah? And there are some counties the ratio is much worse than this, yeah? So if we are not able to have maybe a central point where the decisions are being made, it's going to be very hard to achieve whatever we are trying to achieve here, which is health equity. Yeah? So then I'll say, as of 2019, the insurance coverage in Kenya was 8.4%. And the majority of this was there under the national scheme, which is NHIF. So this also speaks a lot about how well the healthcare access in Kenya, because insurance is supposed to push on you from catastrophic financial implications, yeah, in case you get ill. Because we are usually told that you're one illness away from poverty, right? Because I'm sure you've had it, or even if you've not had any close relative or whoever, maybe admitted in an ICU, you might have someone admitted in an ICU, and within a week, the bill can be beyond 3 million, right? So imagine you had put all this money in savings, you had assets, you had all these things that you've been saving for your whole life. But this is someone who's in the hospitals, it's a very close relative. You'll be forced to sell all these things, right? You'll be forced to liquidate everything, get this person outside the hospital, and you start from scratch, yeah? So seeing an insurance coverage of 8.4% in Kenya is actually really low, because that this means that most people rely on paying out of pocket for their health. Yeah. What happens with this person that I have money to go to the hospital? Will they go to the hospital? No. If it's a mom who's pregnant and they need to deliver, do you think they'll go to the hospital to deliver? No. they'll opt to deliver at home using the birth attendants. So those people who are in the village. And then you tend to see mortality going up, women are complicating. And now this translates to health inequities. Yeah? So you see now how even insurance comes into help accessing health. Yeah? So here I've just given a projection of currently where our maternal mortality rate stands at. Do you remember what we said in 2014? What was the figure? 495, right? So imagine it's 10 years down the line, and that is much progress that we've made. So it's less than 50, right? It's less than 50. And you'd expect that all these measures that have come in. So we've had Linda Mama. Linda Mama is a cover where women are able to deliver free of charge, right? So what we do expect is actually the effect of Linda Mama. You'd have expected our rate to at least have gone to 300, right? Because we provided the free service for moms to be able to access, yeah? But now, clearly, there is a problem because you see, we are still at 443. So the strides have really been very, very minimal, made very minimal progress in terms of this. So this flow diagram here, I'm going to try and explain now how despite the Linda Mama is what I've talked about, the free maternity cover. So that is what we call the pro-poor health financing reforms, whereby you're trying to financially cushion the people who are not very financially able to be able to still access service. Yeah. But now what usually happens is when you do this kind of poor health financing reforms in isolation without considering other factors, that's where you get the outcomes are not as good. That's why you're getting the maternal mortality rate is still not going down, despite us introducing the free maternity cover or even significantly reducing the user fees of the hospital coverage. So on on my left side is what we are calling the demand side of the access barriers. And on my right side is the supply side of the access barriers. Yeah. So the demand side, these are individual factors, community factors, household factors that limit someone from accessing care. Supply side has things to do with the health system, how good the health system is, how well equipped, all these issues. Yeah. So you see geographically on the demand side, there are issues to do things that you don't consider. Let's say these are facilities, a hospital, yeah. So you say there are free maternity services here, but you've not factored in, and these are poor people, yeah. So their level of income is not very good. So you've not factored in where these people live in terms of how long they take to come to the hospital. What do they use to come to the hospital? How are the conditions of their roads? Yeah. Then in terms of the supply side, then in the healthcare side, then not factored in the location of the health facility. For the availability, then yes, there are free services here, right? But have you factored in it about the information about the health services? Do people know about these health services, what that you're providing? Then what is the level of education? Because education usually is a very big factor. You might take a health facility, even a state-of-the-art health facility to a place, but these people are the literacy levels are very low. They don't see the point of them coming to a hospital. So you see, for you think you've solved their problem, but really have you solved their problem? No, you won't have people coming to the hospital. So that is how that is the demand side. That's demand side access. But then for supply side, then when you have this state-of-the-art hospital, say, have you factored in how if you have adequate staff in this facility, if you have drugs, if you have equipment, you have medical supplies. Most of you will bear me witness. If you ever visited a government hospital or you've ever been treated, and I'm not even talking about the government hospitals in Nairobi, in the rural areas in the counties, yeah? It's more often than not that your whole prescription is going to be filled there. So let's say the doctor prescribed 4 drugs. It's going to be almost a miracle for you to find all the 4 drugs within this facility. Yeah? So more often than not, you get 2, you're told to buy 1. You get 3, you're still going to buy 1. Yeah? So and here we're talking about proper health financing reform. So if this is someone who came here, it's not because they had the option of going to Aga Khan and they weren't feeling like going to Aga Khan. It's someone who came here because they actually need this service. Yeah. So when then you start telling this person to actually go and buy other drugs, do you think most of these people buy these drugs? No, right? They don't buy these drugs. So you might have diagnosed very well, but the intervention did not come in handy. Then we look at the demand side in terms of affordability. Then we look at the demand side in terms of ability to pay, the willingness to pay, and the opportunity cost. So you see, ability to pay is one. There is also willingness to pay. So you might tell someone, there's this test, you're supposed to have it, it's 500 shillings. Are they able to pay? That's the first thing. Are they willing to pay? And then what is the opportunity cost? So say this is someone who has 500 shillings, there's this test that you're telling them to have, but this 500 shillings was meant to buy food or was meant to buy a book for their child. Do you think they're going to do that test? They're not going to do that test because they choose the other alternative. They choose the alternative that they feel is much more of a priority to them. So for the supply side, in terms of the affordability, we look at the healthcare costs. These do with informal payments, dual practice. This is where healthcare workers are working in different facilities. Then acceptability, we look at, on the demand side, we look at this through the expectations, assertiveness, health awareness, and grievance redress mechanisms. So everyone will bear me witness that we've had stories of how patients are treated in public hospitals. Yeah. So it's not really sometimes, most of the time, it's not really the best kind of treatment. It's not like I feel like I don't know whether it's the workload or it's people's personality. But sometimes the treatment might not be very good. And sometimes it might be so bad such that someone opts, let me look for alternative kind of treatment as opposed to going back to that hospital. Yeah. So that is also something that should be looked at, even as we are looking at the poor health financing reform. So health financing does not always guarantee health outcomes. Yeah. As we've seen, there are other factors that come into play to actually contribute to this. So then, based on all this background, then what can we say is the role of policy in health equity? So how does policy come in to promote health equity? So remember, these social factors we talked about, all these things to do with the level of education, the literacy level of income, workplace where people live, where people work. Those are all things that can be controlled by policy, right? And if the policy is not able to control these things, so you see, all these are not things that are within the control of the healthcare system. The level of education in the population, that has nothing to do with the healthcare system, right? But does it affect the health outcomes? It does largely, yeah. The level of income, people's level of income, you as the healthcare system, you can really do so much for people's level of income, but does it affect the health outcomes? So what we are saying is health inequities are mostly as a result of policy failure, and thus are avoidable and by improvement of choices in policy. Yeah? And we have to really lobby as much as the health sector has to do its part in addressing the root cause. The root cause is what I looked at here as the supply side. Then there has to be a lot of intersectoral action in terms of now working on the demand side of the access barriers, right? So what are the opportunities? What are the opportunities in terms of policy? So what can we do to actually make these things better? Yeah. So the first thing is the universal health coverage. So universal health coverage is a conversation that has been ongoing. I think everyone has heard of the shift, how we are trying to achieve universal health coverage through the taxation. So it's just one of the mechanisms of raising money for universal health coverage. So what universal health coverage aims to achieve is to protect people from catastrophic expenditure and impoverishment, while still ensuring that they are getting care. So you're getting quality of care. So for all these people, it brings people together in terms of spreading the risk. So just as they're saying, people who earn more push on the people who earn less, and ensuring that everyone is, the difference between the universal health coverage and what we had previously, so the NHIF, is that no one gets preferential treatment. Whether you're contributing 30,000 per month or you're contributing 300,000 per month, the access to services is the same. So that is how you're achieving it's equal treatment. You're not having the people who are contributing 30,000. You see, like the way NHIF had the enhanced scheme for civil servants. So civil servants used to get preferential treatment because they were also contributing more, yeah? Despite the fact that even some people in the private sector were contributing the same amount, but you still were not getting preferential treatment. What they see now is coming to do is prevent.
It's the act of love.
Someone who's kindly unmute, I think. Kindly mute, there's someone who's. Anyway, so as we are saying, one of the opportunities in the universal health coverage by ensuring that everyone in Kenya is getting access to quality of care and they are protected from catastrophic spending and impoverishment. Yeah? The other thing that should happen is leadership reforms. Yeah? So the leadership reforms will help in addressing the inequities in representation by ensuring that the views of the vulnerable and the excluded are heard and their concerns addressed. Yeah? So the people, the leadership who are representing the marginalized people, yeah? The people, say, in the northeastern regions or the people who are really marginalized, having them coming up and actually addressing the inequities. Because if that county does not address issues with infrastructure or issues to do with the low levels of employment there, or just the environment, whatever we do here, whatever kind of reforms we try to create, we are still not going to get good outcomes, right? Then there are issues to do with the service delivery reform. What now display the service, the supply access barriers there. So even the health systems need to consider how they are addressing, how they are actually providing the service, yeah? So that we are meeting people's expectations. We're not having people, there is a hospital within your local, but you'd rather go very many kilometers away because of how the services there are, how the personnel are, how people are being treated. And public policy now comes in terms of ensuring that we are having policies, every policy that has an effect on health, it has to really be taken into consideration. So if you are having policies to do with the free education, ensuring that we have everyone in Kenya is at a good level of literacy, so that we also promote their health seeking. Yeah? So that is how the intersectoral action comes. So here I've listed this commission known as the Commission for the Social Determinants of Health. So it's a commission that looks at how, using the social determinants of health, we are able to achieve equity, and that is what really we'll be talking about. So they comment that one, we need to improve the daily living conditions, including the circumstances in which people live, work, grow, play, and age. Those are all the social determinants of health, right? Then we need to tackle the inequities in the distribution of money and resources. So remember that pictorial presentation of the equality and equity. If there are people, we might come and say, in this population, we are giving you 2 million. But you see, the population needs are different. Remember, there is a tall person, there was a short person. We really want to have the outcome of them being able to get to view the game. That is our outcome, yeah? So if we give everyone a blanket thing, then they're not going to achieve whatever we want to achieve, yeah? So remember, in tackling inequities in the distribution of money and resources, that has to come to mind. People usually I think in Kenya, we do a lot of equality, whereby I think counties get the same amount of money, right? In the budget, yeah? And you see now that doesn't work because people's needs are very different. And how will you be able to know what is needed there? It's through data, and that is the third point, whereby you're supposed to measure and understand the problems and assess the impact of action. So go to a county, measure how the problem is. Go to a different county, measure, so that you tailor-make your solutions to these two people, yeah? Because they are very different. And that's why when we employ blanket kind of solutions, we never achieve exactly what we want to achieve. Then we should have all the policies in government be formulated in consideration with their effect on health, because we've seen there are many other factors outside health that have a direct effect on health. And the vulnerable groups should be given a platform to freely air their views. So collaborative innovation is basically now what can we do to actually achieve, how can we come together? So for in terms of the data and technology, comes in developing or improving information systems in order to collect information on the social gradient and distribution of health in population, which will provide sufficient data for political action and accountability on the determinants of health. So as long as, I usually say, as long as in the public healthcare facility, we still have the manual, but those big files. If you are going to a hospital, we've seen big files. Big files, I think some big registers they use, they're still not adopted technology. And as long as we are in that state, it's going to be very hard for us to do data analytics. Who will going through turning the books and trying to analyze this data? As we need to develop and improve the information system. And I like a lot of countries really now are adopting the health information systems as just what do you say? Yeah, for them now to be able to base the decisions in terms of how they are using the resources. Again, I say different counties, different people. There's a governor who will say, oh, actually it's important for me to have a health information system within their hospitals. But there's another one who will, why do I need this? People can still record in the books or something. Yeah? So you see, that's how now the difference comes in. As long as the decisions are being made at different points, it's going to be very hard to have a uniform kind of outcomes. Then they can improve access in marginalized areas for marginalized groups, e.g. pastoralists, whereby by use of digital powered AI booths. So this, I think, is something that can be implemented. You see, pastoralist communities are very diverse, yeah? So there are people who are moving around. So you can't have like a doctor following them around or a healthcare facility following them around. But right now, with the use of AI, people are leveraging on AI for a lot of things. You can have like a booth in these areas they move around, several booths whereby these people can be sensitized and know this is like a hospital. So if they have problems, they can come, maybe give their presentation, whatever, and this they can also get recommendations. You see, and this by using tech, using AI, you don't have to have a very huge personnel there. We have it's like a clinic setup. You're just taking advantage of tech. So those are the kind of things we can use, like the kind of innovations we can leverage on. How is data? How is technology helping us? How is AI helping us? And I think Terry will talk a lot more on that. Then you can use AI to disaggregate data in health and other sectors based on the social determinants of health. So right now, I think what you're doing with the Datathon, like someone's level of income, ethnicity, those patient characteristics, more or less, they have an influence on how soon the diagnosis of an illness is made, how the treatment outcomes are there. Because you see, if you don't have free healthcare and you don't have money, even if you're diagnosed with, let's say, this form of cancer and you're told this is a treatment regimen, yes, you do have the diagnosis, but you don't have the money. So you just stay home, wait for the money. And now what will happen? The disease is progressing. That's why in Kenya, even in the cancer strategy here, usually it highlighted in Kenya, most people tend to present at very late stage. And why? They might, most of the time, maybe they weren't diagnosed on time, but there are some who are diagnosed on time, but they didn't have the funds. So as long as you don't have something that is paining, you say there was a lump, it was discovered, but it's not paining. So you're still at home looking for money. What happens? By the time now you're presenting to hospital, the disease is really advanced. And now you are having now to, and you know that for cancers, the more advanced the disease is, the worse the clinical outcomes. Yeah. So the cure rates go down, the cost also of treatment goes up, you see. So we end up having very bad outcomes. Then you can also optimize data analytics to improve insurance coverage. So basically, that is my presentation for today. These are my references. If you want to read more, you can read more on that. It's a very interesting topic, health equity. And always remember, at the back of your mind, for health equity, we have to leverage on the social determinants of health for us to achieve, because there are other root causes. It's not just the healthcare system. There are other factors that influence people's health outcomes that are away from health. All right, thank you.